Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, with the recent expiration of the COVID emergency orders, we check in on the state of emergency preparedness in the U.S. Dr. Josh Sharfstein speaks to Dr. Nadine Gracia, President and CEO of Trust for America's Health, an organization that releases annual ratings and rankings of state readiness in a report called Ready or Not. Let's listen.
Dr. Nadine Gracia, thank you so much for coming to talk about the Trust for America's Health recent report on preparedness. How are you?
Doing well. Thanks for the opportunity. It's great to be with you.
Now, this is officially a post-pandemic podcast in the sense that the emergency declaration has expired. We know that COVID-19 is still out there. And this report starts to take a little bit of a look back as it looks forward.
Yeah, that's right. We are transitioning out of the emergency phase of the pandemic, certainly recognize that COVID-19 is still with us. And this report in particular really assesses our nation's level of public health preparedness by looking at states' measure of readiness for all hazards. It's not specifically about the COVID-19 pandemic, but measures indicators of preparedness. And what this year's report found is that 19 states and the District of Columbia performed in the high performance tier, 16 states were in the middle performance tier, and 15 states in the low performance tier.
Now, how has the concept of emergency preparedness changed over the course of the pandemic? I know that Trust for America's Health has been doing this report for a number of years. Is it exactly the same measures every year, or have you paused to think, I wonder whether we should be measuring this differently?
That's a great question. Well, when we actually started this report 20 years ago, public health really wasn't at the table with regards to emergency preparedness. It was the September 11th attacks, the anthrax incidents that really raised a lot of awareness and the need of public health being a part of and at the table as it relates to emergency preparedness and response. And so in those early years, indicators demonstrate that it was very nascent for public health and with regards to having specific types of emergency plans in place. And then the indicators have evolved over time. We continue to look at the literature to assess what are key indicators that really align with public health emergency preparedness. And what we also recognize is that it's not solely about capacity in terms of public health laboratory capacity or workforce capacity, although those are critical indicators and measures and continue to be a part of the report. But it's recognizing that other sectors also have a critical role to play and other factors do, which we've seen, for example, through the pandemic. Issues like the number of employees who use paid time off. That's such an important policy and strategy to be able to have infection control. And so that's where, for example, policymakers and employers and others really have a critical role to play to ensure that the workforce has the capability to stay home if they're ill or take care of someone in their family who's maybe sick.
So that's now a measure of emergency preparedness.
That's correct. That is one of our 10 indicators, along with, factors such as seasonal flu vaccination, which helps to serve as a proxy of looking at vaccination rates and the ability to be able to do vaccination, especially in times of emergency. Looking at patient quality standards and safety standards in hospitals, and water safety, water quality. Again, when we see these environmental issues that exist as well in communities, all of these factors really show that having an all hazards preparedness approach means being prepared for all types of events, whether it's infectious disease outbreaks or pandemics, natural disasters or man-made disasters, as well as bioterrorism.
So it sounds like in the early days, the measures had more to do with, do you have a plan written for a particular type of catastrophe that might happen? But now you're looking more at actual use of, paid sick time, for example, or actual response, such as seasonal flu and influenza vaccination.
That's right. There's a mixture, right, of having, do you have plans in place to be able to surge during times of emergencies? For example, do public health laboratories have that capacity to be able to surge when they're testing capacity in a time of emergency? But it's also, as you just noted, looking at what are the percentage of residents who actually are getting the seasonal flu vaccine. And unfortunately, as a nation, we are well below the national targets. If you look at Healthy People 2030, which recommends 70% for our national target, we're only at just about 51% in the last flu season.
Is an unstated assumption here that in order to be really ready for a crisis, we have to have a strong public health system every year?
Absolutely. And that's why, as we transition out of the emergency phase of the pandemic, now is not the time to turn our attention away from the public health system, because that's been where we failed in the past, is that we have this attention that comes because of the emergency. Everyone then has a real recognition of the need for a strong public health system. And there's an infusion of emergency funding to support the response. And that funding is critically important, but it's one time and it's specific to the emergency. And then unfortunately, when the emergency ends and national attention fades away, we then return to a state where public health and the public health system continues to be in a weakened state as far as its infrastructure, not having the adequate resources, not having the adequate staffing to truly be the modern public health system that is needed to address these types of 21st century health threats.
Now, this year's report has a special focus on equity. Can you tell me about that?
Yeah, we in particular focused on the intersection between health equity and emergency preparedness, and recognizing that the two really are interdependent. The pandemic certainly has highlighted, it exposed longstanding health disparities that exist in far too many communities across the country, where we saw communities of color, people with disabilities, individuals who live in rural areas really suffer the consequences of structural and systemic barriers to health and well-being. But this hasn't been unique to COVID-19. We've seen this in past public health emergencies, whether it's looking at past hurricanes like a Hurricane Katrina. We see this in annual seasonal flu outbreaks. And so this year, we focused on really lessons learned through the pandemic to focus in on how can we actually better measure health equity as it relates to emergency preparedness. And so did some assessments with regards to data that are available, measures and metrics that may be available. For example, looking at CDC's Social Vulnerability Index, looking at other measures like the Census Bureau's Community Resilience Estimate, or work of institutes like the Satcher Health Leadership Institute at Morehouse School of Medicine with their Health Equity Tracker, to be able to look at types of measures that potentially could be integrated into our emergency preparedness measurement, as well as planning and response efforts.
How do you think states are doing in that regard?
There are lessons of states that and localities that really have done important efforts in having partnerships, especially with community-based organizations, faith-based organizations, where they've partnered and leveraged partnerships that they had prior to the pandemic to be able to do outreach and education with regards to the pandemic, to help support testing and access to vaccinations. But we know largely we struggled as it relates to ensuring equity in the response. We struggled in the beginning as it relates to data, where we didn't have disaggregated data by race and ethnicity and other key demographic factors that could pinpoint in particular communities that were being disproportionately impacted. And when we started to see then more concentrated efforts to really improve that data collection and analysis, then we saw greater efforts with regards to ensuring that there was equitable access, for example, to vaccination, equitable access to treatment, and really being able to ensure that we were partnering with those in the communities that actually could reach those who are being disproportionately impacted. But these are lessons that we need to continue beyond the pandemic, is recognizing that those disparities and systemic inequities still exist. And so it's the opportunity to actually strengthen our systems, strengthen those partnerships to be able to ensure that in the next pandemic and in the next emergency, we're even better prepared.
So it sounds like in order to stay prepared, to be prepared, it needs a public health system that's delivering results. It needs plans to scale in a crisis. And it needs to be thinking about equity in multiple dimensions and having a set of partners that can allow it to achieve a whole bunch of different goals.
That's absolutely right. We need to modernize our data systems to ensure that they're interoperable at all levels, local, state, federal, as well as between public health and healthcare, because our data systems are still antiquated. And there have been important investments that have been made because of the COVID emergency legislation. We have to continue those investments. It has to be sustained so that we continue to modernize the system. We still have significant workforce shortages, and the recent funding for public health infrastructure and workforce, that grant that the CDC has just awarded, that's a critical investment into strengthening and shoring up our workforce, because we have what's estimated about a need for 80,000 FTEs that's in state and local health departments to be able to just provide basic public health services. And as it relates to health equity, absolutely, the partnerships are key. That it's not when the emergency happens that those partnerships should be taking place, that we need to continue those partnerships at all levels with trusted community partners, hearing from those with lived experience, and also integrating health equity into the leadership and infrastructure of the response teams, where there are examples of states and localities that actually designated health equity officers that provided support to and leadership in the response to the pandemic. These are some of the opportunities that we have in ensuring that in the future, we'll have an even greater and equitable response to these types of emergencies.
Well, Dr. Gracia, I don't mean to put you on the spot, but maybe could you name one state that did particularly well in this ranking?
Yeah, we had states, for example, like the state of Ohio, and we actually it was in the high performance tier. And we recently held a congressional briefing and webinar that featured the health commissioner from the Columbus of Ohio, describing efforts that they had in particular, for example, around the measles outbreak that happened in the city of Columbus, and the way in which they really addressed outreach and education, partnering with communities to be able to respond to and end a measles outbreak very quickly. So we say this often, that even states in the high performance tier have the opportunity to continue to improve and advance their efforts as it relates to preparedness. So regardless of the level, we note that these are actions that policymakers, health officials, care sector, and others can be taking to really strengthen their public health system and their preparedness for all hazards.
Great. Now, if somebody wants to check out their own state, where can they find this report?
Yes, they can find our report on the TIFA website, which is tifa.org. That's tfah.org.
Dr. Gracia, thanks so much for coming to talk with us about it.
Thank you for the opportunity. Appreciate it.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.